Next on the agenda is Dr. Thomas Chelimsky. We did that flip-flop, and he will, he's had kind of a change in topics, so I'm not sure exactly what your topic is entitled, Dr. Chelimsky, so if you want to be front and center, we'll... Cartoons in the New York Times, love it. So, no, I think it's going to be on orthostatic hypotension, but we'll let Dr. Chelimsky fill you in and tell you for sure.
Good morning. It's great to see so many people here. It's very, thank you for coming. These conferences are very, very wonderful thing. I just learned an enormous amount. Thanks, Dr. Golby, for a very instructive lecture. I learned a lot. Every time I come here, I learn an enormous amount. And I think one of the reasons he emphasized so much, there's a question about, well, why is he talking about PSP? Because from a physician's perspective, it can be very hard to figure out what someone has. And so that's very important for you to understand. It's not that, some doctors, well, there are. I mean, some doctors know more about certain things, obviously. We all know what we've experienced. But the point is that even very experienced doctors can have a lot of trouble diagnosing these things. And I want to see a show of hands. How many people had another diagnosis before the diagnosis of MSA in the room? Yeah. So you can see it's close to a third of people, and that's just not surprising at all. You really see many diagnoses first, and wouldn't be unheard of for one of you to actually ultimately not have MSAs. It can be very difficult. So we changed the order because I thought I would focus more. After looking at Dr. Golby's slides and my slides, they were very similar, and I thought, well, we don't have anyone talking about orthostatic hypotension, which is really my area of expertise anyway. So I thought I would shift, and so I'll make sure that somehow the slides get to Vera or Judy, and then get to you afterwards, because the slides aren't going to correspond exactly. The other thing is, I just want to say a special thank you to Vera and Judy and the whole board who, believe it or not, they were up till 3 o'clock in the morning preparing for this. So this is really important for them, really important for you. They're not going to say anything. They're just going to be happy and spry as they always are, but just appreciate how much work I thought we'd just give them a hand. I don't know if they're here or not, but for the work that they did. Okay, so I'll start. I'm going to cover a little bit of historic background on MSA. You're going to hear some of the things again, but I'm just sort of emphasizing certain aspects of what Dr. Golby said already. They say, if you want to really give a good talk, you should. That was a round of applause for you guys. So, if you should say what you're going to say, and then say it, and then you should just explain what you just said. So we're team tagging on that aspect. Okay, so I'm going to talk a little bit about the thinking, the history of the disease, and then the rest of this actually is, rather than talking about so much the brain, I'll talk a little bit. I'm going to really spend some time on low blood pressure. Just a show of hands, how many people here have an issue with low blood pressure? Yeah, so it's a good percent. How many have a problem with bladder? Okay, so that's great. As Dr. T is going to be focusing on that at the end, next. Okay, so we've already heard what MSA is. It's a disorder that causes specific regions of the brain to lose brain cells. And so we have this constellation of about 5 things or more, depending on how you slice the pie: Parkinsonism, ataxia, urinary incontinence, a very prominent sleep disorder in many, and orthostatic hypotension. And so you've heard that there are 2 types of MSA, or there's also an overlap. So there's MSA that's a Parkinson's disease look-alike, and there's MSA that's a cerebellar disease look-alike. And those were actually separate for a period of time. So in the early 1900s, the cerebellar type was discovered. And maybe what I'll do is I'll mimic those gaits so you understand the difference. So cerebellar really means that you are having trouble maintaining your balance, and that you have trouble with matching what's in your environment with your motor system. So your motor system just doesn't do what you think it ought to be doing in relation to the environment. And so the gait typically will be very wide. And in contrast to that, the it used to be thought as a second separate disorder, was stridonigral degeneration, which is the Parkinsonian type disorder. And that gives you more of a stooped, and Dr. Golby does this much better than I do because he sees this all the time, but gives you kind of a stooped posture and small steps. And the issue there is not so much balance as it is posture. You just can't seem to maintain your ability to navigate in a way that keeps you upright. So in one case, it's a coordination, and in the other case, it's a postural problem fundamentally. And then Shai and Draeger really added the prominent autonomic portion, but still in 1961, this was not known to be single disorder. In 1969, the Graham and Oppenheimer figured out that because of the prominent autonomic features, this was a single disorder. So it's kind of strange to have a disorder that has these two different presentations joined by the autonomic features. But 1989, the glial cytoplasmic inclusions were discovered, and that kind of nailed the nail into the coffin that this was one disease because they had the exact same appearance in the brain. And here they are, and they were shown already. And these, the glia, again, are these supporting cells that help the neurons to function. They probably do way, way more than that. They're probably responsible for a lot of disorders, but we haven't spent anywhere near, we spent billions of dollars studying neurons, and we've only spent millions of dollars studying glia, so we really don't understand them very well. But they probably are a key to many, many disorders that we don't understand. So as a result, we now have this classification. We have MSA-P, which means you have the Parkinsonian type feature, and MSA-C, which means you have the cerebellar type feature. And again, that's those two different types of walk. And a good percent have both. So probably about 15 or 20% of people have both features. Now, I just want to talk about a concept, which is a synapse. What's a synapse? So you understand a little bit about how nerves talk to each other. So if you think about the telephone in your house, there's a wire that goes from the wall to the telephone, and you pick up the phone, and there's no real connections in that wire. The wire is just a straight wire, and so that's kind of the equivalent of a nerve cell. And so a synapse is actually a break in the wire. So when the telephone company puts together a switchboard, that's the old-fashioned kind of way of doing telephones. We don't do that anymore. You have a lot of ways of connecting different things. So a synapse is basically a place in the brain where the signal across two nerves can either stop, go on, or even be amplified. So it allows you to change how signals are processed. And one very important, so this is over here, let's see, yeah. So a synapse is made up of two nerves, one nerve that's talking and one nerve that's listening. And this is the talking cell, we call that, the technical term is the axon, and here we call that the dendrite or the listening cell. And then, so electricity is coming down this cell, stops here, and electricity does not cross over here. Here you've got a chemical that crosses, and the chemical actually makes this cell listen. And so this little, see the chemicals going. It took me a little while to figure out how to do this, but and so the chemical that we're talking about in both Parkinson's disease and multiple system atrophy is a chemical called dopamine. But in Parkinson's disease, the problem is with the talking cell. So that's not so hard. You can actually help, because we discovered L-DOPA, you can actually help that cell get some more DOPA and make more DOPA, which is what Dr. Golby was talking about, the reason why the lifespan in Parkinson's disease is better. But with multiple system atrophy, the problem is not with the talking cell, the problem is with the listening cell. So these cells are gone, so you can make as much dopamine as you want. Early on, it might help a little bit, and it does sometimes for a year or so. But then afterwards, when these cells are gone, guess what? Making more dopamine isn't going to help because the listening cell is gone. So that's the fundamental problem, and that's why it's so more difficult to treat multiple system atrophy than it is to treat Parkinson's disease. This is, again, kind of a look at the brain, and this is where the action is for the motor disorders. This is where the action is for bladder problems here. Sorry, let me just orient you. This is the front of the brain. This is the back of the brain. The eyes would be right here. And this is a cut right through the middle, like this. We just cut right through the middle of the brain so you can see what's where. And so this would be, we call that frontal cortex. This would be occipital cortex, the back part. You can see that the action in MSA, as Dr. Golby pointed out, is not anywhere in the cortex. It's all down here in a very small, probably 2 inches of brain altogether, 2 to 3 inches of brain, this whole thing. So basal ganglia, here's where the bladder control is, here's where you control blood pressure, and here's the cerebellum that's affected in the parts, in the patients that have the cerebellar problem. Okay, so we covered this already, and Dr. Golby did a better job than I am. So what do the basal ganglia do? Well, you can kind of think of them like the hearts. They're kind of a pacemaker. They pace your body. If you're very excited, emotional about something, you're going to be moving pretty quickly, and the basal ganglia would do that. They maintain posture, and they harmonize really with the internal environment. They make sure that what you're thinking, what you're feeling, and so on, match your motor system. And if you think about the cerebellum, really its job is to harmonize with the external environment. So, you know, the typical, so where you find your cerebellum working is somebody played a joke on you, and they put like 100 pounds of lead in your briefcase, and you don't know about it, and you go to pick up your briefcase to go home, and boop, you can't pick it up. You let it go right away, right? You let it go. You didn't have all that thinking of, oh, wow, this is heavier than usual. It takes you a millisecond to drop it, right? And why does that do that? Because the cerebellum is constantly monitoring. It's monitoring how fast it knows, you pick up a 5 or 10 pound briefcase, about how fast your arm should fold up. And the moment your arm is not folding up the same way your brain thought it should, then it says, well, something's wrong. There's a mismatch. So it's entirely a matching organ, and it's completely designed as a match. It matches what ought to be with what is. And if you don't have that, then you have inability to keep on target and inability to and it also, of course, includes posture in a way that includes balance. So how often does MSA happen? Well, a pretty good study shows it's about 4.4 per 100,000. And it's about 2/3 Parkinsonian, 1/3 cerebellar. And that's about somewhere around 1/20th Parkinson's disease, maybe even less. So it's very uncommon compared to Parkinson's disease. So I'm going to now talk a little bit about autonomic features in orthostatic hypotension. This is a nice study. It was also actually 2003. So if you have orthostatic hypotension, and you come to my office, and I'm an autonomic doctor or a movement disorders doctor, and I see you, should I diagnose you with is it more likely you're going to have Scheidegger, or is it more likely you're going to have Parkinson's disease? Well, doctors tend to think Scheidegger is associated with orthostatic hypotension, a drop in blood pressure when you stand up. But it turns out, so if you look at this slide here, this is a change in blood pressure, and these are patients with Parkinson's disease, patients with multiple system atrophy, and patients with PSP. So first, let me emphasize what Dr. Golby already said. Patients with PSP just don't drop their blood pressure. They don't drop their blood pressure much. So the higher you go, the more the drop in blood pressure. So this is a -30, this is -20, and this is -10. We generally consider up to -15 or 20 to be normal. So you have to really exceed 20 to be abnormal. So if you look at patients with Parkinson's disease, the majority don't drop their blood pressure, right? Expected. Look at patients with multiple system atrophy, the majority do drop their blood pressure. Again, expected. But if you look at all the patients who come to the office with a drop in blood pressure, they're more likely to have Parkinson's disease and multiple system atrophy, simply because there are so many more patients with Parkinson's disease. So don't be upset if you got diagnosed with Parkinson's disease or if people are still debating what you have, because it's hard to tell the difference. Okay, so why do we develop orthostatic intolerance? So our closest partner, the giraffe, actually not at all close partner, the giraffe does not get orthostatic hypotension. If it did, it'd be in big trouble in the Serengeti when it bends down to drink and stands up because there's a lion right after it would faint. And we've never, anyone raise your hand, have you ever seen a giraffe faint? They do not faint. And why is it the giraffes that are so much taller than we are do not faint? By the way, if you ever want to study a fascinating animal, I taught a course to undergraduates about orthostatic problems, autonomic problems, and part of that, we went to the zoo and had an expert in giraffes who told us all about giraffes. And they actually have valves in their carotids to make sure the blood doesn't flow back to the heart. And so when they bend down to drink, they actually have a problem because their blood pressure, in order to maintain the pressure that they need in their brain, their blood pressure at heart level is about 250, and their blood pressure in the foot level is about 400 millimeters of mercury. 400 millimeters of mercury. So that means when they bend their head down, what's the pressure in their brain? 400 millimeters of mercury. So that's the problem. That's gonna, they're all going to go, if they don't faint, they're going to go over with aneurysms. But they don't. And why is that? Because around their cheeks are these little, it's called rete mirabilis, it's a little miraculous set of vessels that divert the blood flow from the brain to the cheeks. So they don't get any blood in the brain while they're bending down. That's why they can't bend down for very long. But they're not that smart, so they may not need that much blood. But anyway, so that's how they divert, and so they have to divert. So this is a little tongue-in-cheek, but it's all true what I'm telling you. And the point is that they manage this incredible differential in blood pressure from about the same as we have in the brain, 75 millimeters of mercury, to 400 millimeters of mercury, and they manage it very, very well. Why do we not? Why do we have problems with fainting? And why they have degenerative disorders as well as we do, but they don't faint. So the reason is because they have stockings around their legs. So the first thing the veterinarian told us at the zoo is, look at a giraffe, it's basically a cow on stilts. And so remember that next time you go to the zoo. You look at a giraffe, it's a cow on stilts. And the reason it's on stilts is because there's almost no muscle in here. And so really, and most of the blood is actually above is above the heart level. 75% of the blood is above the heart rate level. When we stand up, it's a miracle. It's a miracle that any one of us can stand up. About 60% of the blood is below heart level. So we are actually pumping an enormous amount of blood to maintain the brain to run. If I designed this, I would have put the brain somewhere, pelvis or in the toe. You know, why do it up here? But we weren't designed that way, so you have to get the blood up there. And so, so getting blood back up is incredibly hard. There's a lot of muscle in here, but we have a lot of different things we use. We use 3 basic methods to get blood back up to the brain. One is we have a muscle pump. Another, so when you activate your muscles, that's why, how many have had a tilt table test? So, not that many, interesting. So, when you're on the tilt table, we kind of lean you back at 70 degrees. Why do we do that? Because we don't want your muscle pump active. We want to make it as possible, as likely as possible that you're actually going to faint if that's going to happen. It's fun, isn't it? Right. So, so we have the muscle pump. The second thing is we have these vessels that are very active and require nerves to tell them, okay, the person stood up, you better contract, you better constrict. And when that doesn't happen, guess what? The vessels do not constrict, and then you wind up with orthostatic hypotension. So the base of orthostatic hypotension is that the vessels down here and in the abdomen don't tighten up on command because the nerves are not working. Now, there's different ways the nerves cannot work. Diabetes is another disorder that's got a lot of low blood pressure associated with it. That's the nerves themselves. In multiple system atrophy, we know by and large the nerves are working pretty well, but what's happening is that the brain is not issuing the command. So the command center is not working. So you stand up, the vessels don't tighten up, and you wind up with not enough blood pressure to feed your brain. And then the third mechanism we have is actually our brain is under negative pressure when we stand up. And that will suck blood back up into the brain. And that works fine in multiple system atrophy. And how much of a mechanism that is, we don't really know, but we know it's definitely true, and it's definitely a mechanism to get blood into the brain. Okay, so you may have heard there's other disorders of orthostatic management, other disorders of blood of making sure. And so this disorder called postural tachycardia syndrome, there's a disorder called reflex syncope, in which that's just basically a faint, you pass out. And so this is a spectrum. This orthostatic hypotension. Really, nobody, or very, I've never seen a patient with multiple system atrophy have postural tachycardia syndrome. That's defined as your heart rate goes up by 30 beats per minute or more in the first 10 minutes, and you cannot have a drop in blood pressure. Otherwise, is orthostatic hypotension. If you have a drop in blood pressure, the heart rate went up to compensate. So that's orthostatic hypotension. Whereas orthostatic hypotension is defined by the drop in blood pressure. We define it as greater than 20 millimeters of mercury, systolic, greater than 10 millimeters of mercury, diastolic. And this is a little cartoon that shows you the tilt table test, or if a person stands up. So this is blood pressure, and this is heart rate. So with orthostatic hypotension, blood pressure drops, and heart rate goes up. With postural tachycardia syndrome, blood pressure stays about the same, and heart rate goes sky high. And syncope, reflex syncope, classically, you have a normal blood pressure, normal heart rate, and suddenly, boom, the heart rate and the blood pressure will drop together. So that's the three disorders. The important thing is these really don't overlap a lot. They're all in the dysautonomia, the general dysautonomia category, but these generally are what we would call structural or disease-based, and there's an abnormality in the way the autonomic nervous system is structurally functioning. These, so far, we really don't understand what's going on. I call them syndromic, means that it's a set of symptoms. The autonomic nervous system is not working properly. There's a function abnormality. But as far as we can tell so far, by and large, the structure of the autonomic nervous system is working, or is intact. So this is a difference between these two types of disorders. This is a tilt study in a patient, and it looks like I don't have. So this person starts, here's the blood pressure, and I don't think you can see this very well, but this is about 140 over 80. Then you tilt them up right here. This is where they go up, and they drop abruptly, and then they recover. This is a very typical scenario. They're kind of all over the place because they're really working to recover. They're dropping, and then the heart rate, you see, is making a very minimal effort at covering, at increasing the heart rate to try to compensate. And then all of a sudden they drop further, and now they're going to pass out. In our lab, we do not let people actually pass out. We just let them come close. And then, so then at about 34 minutes, the person was tilted back. I think the important thing this is not on here. I don't know if it got hidden or what, but the original slide said, no symptoms, exclamation point. So the person is having a blood pressure of 80 over 60 and having no symptoms at all. And that is not uncommon, as I'll show you in the next slide. Totally the opposite of POTS. Not that you need to worry about POTS, but I worry about it. And POTS, they have a heart rate increase. The blood pressure is fine, and they have a lot of symptoms. So something in the brain stem, something in our nervous system, I think is a clue about these two different types of disorders. That's in one case, the symptoms are very felt, and in the other case, the symptoms are actually nullified. You don't even get them. So how often do people not have symptoms when they are orthostatic? So we looked back at our population of people that have orthostatic hypotension, and we didn't want mild. We didn't want people that just had 10 or 20 millimeters. We wanted people that really had orthostatic hypotension. So we started with a 60 millimeter drop. So that was, to get in the study, you had to have dropped 60 millimeters of mercury. And on average, this group, all told, were dropping about 90 millimeters of mercury. That's a lot. So they're going, say, from 180 to 90 systolic. So we looked to see how many people had symptoms. We asked, the way we do our tilt tables is every 2 or 3 minutes, we're asking, what are your symptoms? Are you having symptoms? Anything wrong? What's going on? And so we're not just waiting for the patient to tell us, we're actually asking them. And over time, we started seeing that people were just down to 80, just not complaining about anything. So we looked at this retrospectively. We found that only about 1/3 of our patients, only 1/3 of our patients had typical symptoms. About 1/3 had atypical symptoms, and about a full third were completely asymptomatic. No symptoms at all, down to pressures of 60, 70 systolic. So what's the point here? Don't assume because a person doesn't get lightheaded, doesn't get dizzy, that a fall is due to something other than your blood pressure. The blood pressure could still be dropping, and although I haven't proven this, my argument is, well, what's the first thing to go if your blood pressure starts dropping? Probably the part of the brain that works least well in the first place. So if you've got a part of the brain that's already a little bit compromised and a part of the brain that's working well, the one that's already compromised, you drop the blood pressure, there's less oxygen, that's going to stop working. So I've often thought that in multiple system atrophy and orthostatic hypotension, some of the falls that look like they're related to your balance or related, maybe that actually your blood pressure is dropping and you don't know about it. So that's keep that in mind. Okay, so treatment. How do you treat orthostatic hypotension? So we've defined it, we talked about it a little bit. This may surprise you or it may not, but non-pharmacologic treatment is more important than pharmacologic treatment. So what you do that's not drugs is way more important than what you do that is drugs. And this shows the change in blood pressure and plasma volume and how long a person took to pass out with these we call them non-pharmacologic, non-drug methods. So this is placebo, nothing. This is when you supplement with salt, and this is 4 grams a day. This is when you raise the head of your bed up at night. And I'll talk in a minute about why you should do that. And this is when you exercise. And these are 3 very, very important non-pharmacologic things everyone should be doing. And so you can see here that head up of the bed, some people didn't really respond, but some people respond beautifully with a big increase in how much volume they have available. By the way, plasma volume is the measurement of how much venous blood, if you will, is available to you. And when your vessels don't constrict, they don't tighten up properly, which we understand is the basic problem, then you can't make them constrict necessarily. You can't do that. But another way to do it is just to make the amount of water bigger. So you got more water, you don't constrict quite as well, you just got more, you've just filled up the tank better. So that's why we're measuring plasma volume here. So increasing salt is obviously very effective. Exercise is quite effective. Placebo doesn't work very well, except for this one person out here. I don't know what they were doing, but they had an incredible response to placebo. But that tells you the data are true, because otherwise you wouldn't like to admit this. So why does heading, so everyone understands salt leads to taking in water. So when you take in salt, you're expanding how much volume you have. And so about 2-3 grams a day. Do this under the supervision of a physician, though. Do not do this yourself. You need to check your blood pressure. You need to make sure your blood pressure is not going too high, which is a separate problem. And if you take salt, you want to take salt during the day when you're going to be up and around. It only lasts for about 4 or 5 hours. So you take it in the morning. Maybe you take a nap in the afternoon, you take it at 3 o'clock in the afternoon, and that's all you need. And you don't take it again at night, because you don't want to be taking it before your blood pressure, before you need your blood pressure now to be low when you're sleeping. Then head up of the bed. Why would that work? Well, turns out, why do you think all the astronauts that come back from space, their pictures are always taken in an astronaut suit? You know why? So they can look good, right? No, that's not why. Because if they weren't in the astronaut suit, they'd be passing out. And the reason they pass out is because gravity is an critical stimulus to keep the blood pressure mechanisms working. When you're in outer space it only takes about 3 days in outer space. If you're in outer space for 3 days with no gravity, you basically lose all those mechanisms. And so that's why they're all taking this, in the pictures are taking the suits. By the way, the suits were taken from the giraffes. So in the 40s, I'm not kidding, in the 40s and 50s, NASA studied the giraffes that have these incredible natural stockings, and that's how they developed the NASA spacesuits. So what does elevating, what does that have to do with the price of eggs? Well, elevating the head of the bed is a way of making gravity more effective. So you make gravity more effective. You don't get rid of as much fluid during the night, so you have more fluid to start off with in the morning. By the way, you don't get up to urinate as often, because your kidney's not making as much water. So it's a very effective way to treat nocturia. And so that's very important. How high should you elevate it? As high as you can without winding up as a crump at the bottom of the bed in the morning. So some people can get 1 brick, some people can get 2 bricks. Sometimes your partner will argue. So you have to compromise all those things. But as high as you can go, higher is better. But you still need to make sure your sleep is good. Okay, now this is another non-pharmacologic method, tilt training. So just like muscles, blood vessels can be trained. So you can't train them against the degeneration, but you can maintain them, you can maintain better. So now it's been clearly shown, no question about it, Parkinson's disease way improved if you exercise. Way is no question. So multiple system atrophy is too small a population to do the same study, but there's no question in my mind that multiple system atrophy benefits enormously if you can do core training exercises, regular exercises. Those all benefit you. Maintain what you have for a longer period of time. And actually, the study that did Parkinson's showed that the mitochondria in the brain are better, function better after exercise. Not the mitochondria in the muscle, which kind of you'd expect. Mitochondria in the brain function better. So this is exercising the vessels, if you will. So when are you most likely to faint? Well, when you're standing in line at a drugstore, right? So you basically stand in line. You stand against the wall at about, about 1.5 feet away from the wall. Their feet about 1.5 feet away, just like you'd be on a tilt table. Stand with your shoulders up against the wall. Do it in a carpeted area where if you do faint, you don't wind up hurting yourself. And you do that until you can get up to about 5 or 10 minutes. When you first start, you can only maybe do 2 or 3 minutes. And you push yourself. Try not to faint. You don't want to faint. You want to just stay up as long as you can. But you'll notice that your endurance increases over time. So you will actually increase the ability of your vessels to send blood back up to the brain. So, and the point of this Japanese study was, these are patients with syncope. By the way, they don't have, passing out is not a degenerative disorder, so it's not fair to compare them to multiple system atrophy. So, but they were able to get back up to a 30-minute standing after 15 days of training. You will not be able to do the same, but you'll notice a significant improvement. Okay, now the counter maneuvers are all very important. So leg crossing, toe raising, and squatting. These are available on the internet. So they're called physical counter maneuvers. And they're ways of avoiding your blood pressure dropping using, since the vessels are not getting the command from the brain to constrict, then what you can do is you can use the muscles. The muscles are still working. So you can use the muscles. You can do a pumping exercise. You can do a leg crossing exercise, toe raise, and squatting. And these are all very helpful if you still have your motor system intact to make your blood pressure go up at the time and make yourself be able to stay up longer. And here they are in picture form. This is the so-called party posture, because you can do this at a party and look like you're okay. This might not be so good to do at a party, but you can see the blood pressure that results in all of these. And this might be okay at a party if everyone else is sitting around. And at a bar, I suppose this might work okay. And you can see the blood pressure that goes up with all of these. Okay. Now, this is a person who was passing out and shows you the dramatic impact of a squat. So here this person is sitting on a tilt table, and they start, this little squiggle means they're getting lightheaded. So they're getting lightheaded, the blood pressure starts to drop, and then they do a squat. No, I'm sorry, I think they're doing a leg crossing exercise here. Blood pressure comes right back up. Then they start getting dizzy again. Blood pressure drops. They do it again, comes back up. Then they take the poor person off the tilt table finally. They're standing up. Same thing happens. Cross the legs again. Same thing happens. Cross the legs again. Same thing happens. Now they're going to do a squat. And look at the squat. Look at the blood pressure rise that you get with a squat. And then finally they let the person sit down and the experiment's over. Now, another non-pharmacologic, you think I'm kidding about non-pharmacologic measures, but I'm not. So another one is water drinking. So David Robertson, who could not come here and is really a mentor to me in many ways, he pioneered this whole, he always emphasized to me how much he learned from the patients. So you think you're learning from me, I'm really learning from you. So being here, I get a lot of ideas about what would be a good research project or something that's really important to you. Anyway, he got this from a patient. The patient said to him, Dr. Robertson, you know, it's interesting. I drink a glass of water, and I'm fine for an hour or two. I don't even need any drugs. And so he ignored it. And then he heard it again from another one. And I think he ignored it again. And then he heard from the third person. He said, I better look into this. So he did these studies that show that when you drink 240, it was 240 cc's, about 10 Who's a quick translator in their brain? What is that, 16 ounces? What? 8 ounces? Yeah, okay, right. So 8 ounces, thank you. 8 ounces of water. 8 ounces of water, you drink that first thing in the morning before you get a chance to get your drugs on board, and it will increase your blood pressure enormously, 40 millimeters of mercury. And his current thinking is that the biggest stimulus to blood pressure is water drinking, and the biggest stimulus to dropping blood pressure is eating. So if you can manage how you eat, eating in small meals, and when and how you drink water. Now, it doesn't work if it's salt water, remind you. And I told you have to take salt in, right? So you have to do those separately. You got to take the salt as a pill, and you got to take the water as just plain old water. But if you can manage those two things, you've got a long way in terms of how you manage your blood pressure already. So it must be hypoosmolar, means you can't have any salt. He found 16 ounces to be a little bit better. People have trouble drinking 16 ounces. Then you have to go pee, and you got all the problem with the bladder. And so probably I would just stick with the 8 ounces. Okay. Now, this is just the only point I want to make. This is a little technical, and I don't want to get into technical detail, but I do want to make a point that things are never as simple as they seem. Salt should just be a volume expander, right? You should just take salt and expand your volume. Well, it turns out that salt does way more than that. So the reason why salt is so bad for people that have hypertension is because it messes with the whole nitric oxide synthase system, and it screws up your, that system is what dilates your vessels. And so when you take salt, what you're actually doing is you're stopping the vessels from dilating quite as much. So there's always something more, we're always learning more about stuff, and so it's not just that it increases your volume. Okay, now pharmacologic management. I'm actually not going to spend as much time about that for two reasons. First of all, your doctor knows much more about that, and secondly, you can't control it as much. And third, it's not as important. It's the non-pharmacologic that counts. But we have mitodrene. Mitodrene has been around for a long time, and it's a good drug. You get it. Basically, what it does is it substitutes for the nerves, but it doesn't do a very good job. And so the most you can get out of it is probably 20, 30 millimeters of mercury if you're lucky. When I say it doesn't do a very good job, I'm not putting the drug down at all. It's a great drug. I'm just saying we just don't have a drug that does better. It's good because it doesn't get into the brain. It lasts about 4 hours, so you don't have the problem of night. And by the way, the drug, the FDA thing says take it 3 times a day. Don't take it 3 times a day. Take it twice a day. So take it when you first get up in the morning, then take a nap in the afternoon. So your blood pressure has a chance to rest. And then take it again at about 3 or 4 o'clock in the afternoon, so you've got another good 4 hours. And you could take a little bit more that way. So you might be able to take, because the maximum daily dose is about 60 milligrams, you could actually take 30 milligrams twice a day that way instead of 20 and get a little bit more bang for your buck. And that's not what I have on the slide here. But okay. Now, it's important not to lie down once you have it because it really is boosting your blood pressure. Fluorocortisone has been around for a very long time, and it is a mineralocorticoid. That means it's a steroid. It's basically a steroid. And so it has steroid side effects, bone thinning. It also messes with your potassium, so you have to check potassium. And so it does increase volume. Again, so here's another, one of these things you just never know what drugs do. So salt, we thought it just increases volume. Fluorocortisone, we thought it just increases volume by acting like one of the hormones called aldosterone that the kidney makes. But actually, it does way more. It actually makes, so mitodrene hits a receptor called the alpha receptor. And fluorocortisone actually sensitizes, makes the alpha receptors work better. We don't know if it increases the number or if it just makes them more sensitive, but it increases. So it's a great pair. Fluorocortisone and mitodrene are a great pair because it makes mitodrene more effective. Pyritostigmine, we were just talking about that earlier this morning. Pyritostigmine is a drug classically used in a disease called myasthenia gravis. And what it does is it makes remember that synapse I showed you early on? There's a synapse sitting in what we call the ganglia, which is just outside the spinal cord that communicates the information from the central nervous system out to the peripheral nervous system. So this drug actually makes that synapse work way better. Now, if the brain is going to be completely quiet and say nothing when you stand up, this drug will not do anything because it just takes advantage of any signal that comes out and amplifies it. But it is a pretty good drug. You don't have quite as much problem with lying flats and the high blood pressures you get lying flat with this drug. So that's a benefit. And so this graph just shows that both systolic and diastolic blood pressure go up. And this is Philip Lowe's group in Mayo who did this. Okay, and this is another one on that. Okay, then I did want to mention there is a medication that is supposed to, I don't have a slide for it, but there's a medication called droxydopa, which is really still having a lot of trouble getting itself approved by the FDA. So I'll just put a plug in for it. I was doing some of the trials. It works very well. If you want to write a letter to the FDA, if any of you have been on it, how many have been on droxydopa? Any? Interesting. Okay, well, you're not going to write a letter to the FDA, I guess. But it's a great drug. It's a drug. It's like L-DOPA. It boosts. So L-DOPA increases how much dopamine is in the brain. Droxydopa boosts how much norepinephrine is in the nerves. So it works really well. The patients love it. The patients I put on love it. It's having a lot of trouble in the FDA. And mitodrene actually almost got terminated. It almost got pulled off the market. And the FDA just doesn't seem to understand that this is an orphan population. This is not so easy to do these drug trials. And we need more of these drugs available on the market. So if you have it, if you're kind of moved to do it, write it out of the FDA and tell them, look, we need mitodrene here. We need droxydopa approved. And they, for some reason, they're pretty responsive. So that's how mitodrene got back on the market. It was going to be pulled. Mitodrene got back on the market because of the amount of the deluge of patient letters. Okay. These tips are just about depression. Make sure you don't ignore depression. The bladder is going to be covered by Dr. T. And so I'm going to stop there. Thank you.
Thank you, Dr. Chelimsky. Okay. When he mentioned the FDA, I think in your packets there was like a sample letter that you can actually write to your congressmen and senators and all those political people in this election year. They may be a little bit more tuned to looking and listening at what the consumers want. And even though you all, I don't think anybody had a show of hands that they had been on droxydopa, I went down to the FDA hearings in February, and it was amazing the patient response that was given at that hearing. And we might later on this afternoon hear a little bit from a Chelsea pharmaceutical rep who introduced earlier on our board. So, but right now we are going to take a very quick, like 5 or 6 minute break because we want to make sure Dr. T gets his full allotment of time.